I am so pleased to welcome our 4 panelists this evening. We are going to go through the topics one by one just to kind of keep it a little more organized. But we do have a microphone that will be available in the audience so that people can ask questions. Tamor will come around. Just raise your hand if you have a question. I'm going to introduce our speakers, but we would love to have audience engagement, and that's why we're here this evening, is to really answer those burning questions you might have for our physicians. I'm going to start with Dr. Stephanie Liu. She is a family physician and founder of By Dr. Mom. She completed her undergraduate degree at the University of Calgary in Health Sciences and subsequently completed a Master of Science in Clinical Nutrition at Columbia University in New York City. Her medical school and residency in family medicine were completed at the University of Alberta, and currently she practices community family medicine with a special interest in pediatrics and women's health. She's also involved in medical education as an assistant clinical professor at the University of Alberta. In November of 2018, Dr. Liu created a parenting blog called The Life of Dr. Mom, which you can also find online, where she discusses her experience as a first-time mom and provides evidence-based child and maternal health information. Her goal is to provide families with credible medical information so they can make informed decisions about their health and the health of their loved ones. Dr. Liu has been a fierce champion of the health of women and children and is a proud supporter of the Lois Hospital Women's Society as well. In early 2021, Dr. Liu donated 200 copies of her book, Georgie Shark and COVID-19, which really explained to our littles what was happening in the world at the time. She donated those to the families at the Lois Hospital for Women, along with a portion of the proceeds from book sales to the Lois Hospital Women's Society. Since then, she's collaborated with the Women's Society on countless initiatives, and she's now here to join us this evening. So welcome, Dr. Liu. So I will kick things off, but please join us in asking your own questions. Dr. Liu, there's been a lot of talk in the media lately around contraception, and more specifically, hormonal contraception options. From birth control pills to IUDs, what should women look into when they are making these decisions for themselves? And does this change as women enter their perimenopause and menopause stages of their lives?
Okay, so that's an excellent question. I actually talk a lot about contraception in my family medicine practice. Before I even answer that though, I have to say, when I was walking here, I was freaking exhausted. I just gotten from a flight from Houston. I was up at 4 a.m. And then from seeing you guys, listening to the speakers, I feel like I just had 3 Red Bulls. I feel energized. I feel so good just being with you guys, seeing my friends, seeing Melanie, who I don't see as much as I like, seeing all of you wonderful people. And I even have friends in the audience, like Georgia over there, that is also a Lois Health member that is taking photos for me, so thank you. Okay, so let's talk contraception. So hormonal birth control as the name implies, is something that we can do to prevent pregnancy. But there's other indications too. So if someone has a really painful period or a really heavy period, hormonal birth control can help kind of modulate that too. The other thing, so once you talk about the indications, the other things I always talk about with my patients are, well, what are the risks? So one of the risks that a lot of people talk about are blood clots. So there are some people where I'll say, hormonal birth control is not right for you. And those are people with a previous history of blood clot, if they have an active cancer, because people with cancer are at a higher risk of getting blood clots. So I always talk about when you should not also be taking a medication. And then I always go through what are all of the options available. So there's many, but the most common being the birth control pill. Another one being the patch, where you apply it and then you leave it on for a few weeks, then you take it off. Something called the NuvaRing, where you put it in the vagina, you leave it in there for a few weeks, and then you take it out. And then one of the most commonly one that's being talked about is the IUD. So when I talk to my patients, I'll say, what are you kind of interested in? And I lay out all the options. I talk about, the benefits of some versus the other. If we have someone that's, really not good at taking medications, and for them it's very important to not get pregnant, the birth control pill may not be the right option. For someone that's really, really scared of procedures, the IUD may not be the right option for them too. And so we always talk about what the options are out there. You brought up another question. You said, what happens if for perimenopause, right?
Yeah, I think as women, and myself included, head into the perimenopause stage of our lives, it's definitely a topic of conversation for my friends and I of what now? Should we change? Should we stay the course? Some of us our relationship status has changed, which affects your need for birth control. So I think just your advice on that as well.
Yeah. So perimenopause, I'm probably going to be hitting that in a few years too. It's a wonky time. So, your periods can get irregular. You start potentially even developing symptoms of menopause right away, hot flashes, things like that too. And so when you are going through perimenopause, you can still be on birth control. And why I sometimes encourage it and talk about it still is when you're going through perimenopause and your cycles are irregular, you can still get pregnant. I think a lot of us know one person that actually got pregnant when they were 49, 50 with an unplanned pregnancy because they thought that if you're going through perimenopause, you won't be able to get pregnant, but you potentially can. So I still talk about using birth control to prevent pregnancy, but it can also help regulate the wonky periods that you get as you enter perimenopause too.
Any other questions on the topic of contraception before we change over? Not seeing any. I'm going to flip the script right over and we're going to go all the way down and talk about our children. But another hot topic of late has been the conversation around technology and the child brain development and the dramatic increase in rates of depression and anxiety in our youth. Is there any insight you can offer in this area and provide your thoughts on the technology use in children and young adults?
So these aren't easy questions, but I will. Social media is a weird thing. I'm on social media. I think many of us in the room are on social media, and I'm an adult. And, social media can even mess with my mind. Sometimes I get down on myself. Do you guys know what FOMO is? I learned that from my young patients. And I get FOMO. I see all of my other friends, they're out having fun. I'm at home, grumpy, and it can really mess with your mind. And so I think about a young adolescent's mind. And they're going through so many changes, and being exposed to social media, I think, can be so tough from a mental health standpoint. And there's also a lot of scary people online. So that's one other thing I think about when I think about social media. The other thing, so I was in Houston for the American Academy of Sleep Medicine conference. And another thing with sleep medicine is they've done a lot of research on this, and they found that the adolescents that had social media were more likely to go to sleep later and for sleep for shorter durations. And we know how important sleep is for an adolescent's mind. And then with technology, my husband's here too, and we have little kids. And I'll say my kids are screen time addicts. We had to give them a cleanse recently because it's tough, right? Because I think about it for us, like there's something, sometimes when I unwind, I like watching the TikTok cat videos, things like that, right? And with our kids, I don't think it's realistic to say no screen time, right? We're all busy, and sometimes screen time can really help as for family unwinding times. One of our favorite things to do are family movie nights, which we really enjoy. But I think the important thing is with screen time is moderation, is really making sure that there's limits in place, and they're also monitoring what kids are watching. YouTube, some of the stuff that's out there is so funky chicken. It's the weirdest stuff you will see out there. And it's scary because this is kids' YouTube. So in summary, social media, we're in an era where a lot of people are on social media. There's some good things about it. But for a young adolescent's mind, I think we need to really be cautious about who they're engaging with, what they're seeing, and also putting time limits in place. And then with screen time for our littles, what we try to do is really limit the screen time, but also, use it as a treat. So weekends, we really love movie nights and things like that.
Amazing. Any other questions on the topic? And you can continue to add too. I won't blab. But our next question, we were thinking about heading into summer weather. Can you share more about heat-related illness? And I know it doesn't always get super hot here in Edmonton, but what should we be aware of for ourselves and our children, and just kind of what to watch out for as we head into the warmer weather?
Yes, I actually really, this is the easiest one of them all, which I like. And so for little ones, it's really important to be aware of that because kids don't thermoregulate, babies don't thermoregulate as well as adults do. So always checking to see, even using your hand to see what their skin temperature feels like is a good thing to do. Monitoring urine output is really important. So, even for us, one way to tell if you're hydrated is looking at the color of your pee. Does anyone know what color our pee should look like? Who said faint yellow? You're right. You got it going on. That is exactly correct. So looking at the color of our urine is also a really good thing to do. Making sure that when we think we could be dehydrated, that we're rehydrating correctly. So straight up juice, 100% juice is not the right way to hydrate. If you are dehydrated, water alone isn't the best. And what you need to rehydrate is you need some type of sugar, you need some salts, and the amount of sugar needs to be diluted. So if one easy way to do it is if you take half juice, half water, and you mix it, that's a good way to rehydrate. And then you know what, I'm gonna go for it. I'm gonna throw in a plug for my own product. It's actually our product. So my background was in nutrition, and Graham was in biochemistry, and we have really good friends. They own Fresh Fruit BC, and they make the best apple juice. So essentially what we did was we took apple juice, diluted it to the correct amount, and then added in all the essential electrolytes. And it's called POM MD. Yeah. Safeway, Sobeys, at all farmer market locations. Yeah.
Amazing. Perfect. Any other questions for Dr. Liu? We're going to move on. And as questions come up, we can always circle back, but we're going to move on to our next panelist here for the evening. So Dr. Lashan Peiris is an oncoplastic and reconstructive breast and general surgeon and associate clinical professor with the Division of Surgery at the University of Alberta. He specializes in surgical management of breast disease and total breast reconstruction. Dr. Peiris graduated from Imperial College School of Medicine in London and undertook his surgical training in London and throughout the south of England. During this training, he developed a keen interest in managing both benign and malignant disorders of the breast. Dr. Peiris is also the clinical lead of the Comprehensive Breast Care Program, which provides education and navigation to all Edmonton Zone and Northern Alberta patients with benign and malignant breast issues. In December of 2022, Dr. Peiris led an informative and engaging session all about breast health for our Between Us speaker series. With 1 in 8 women in Canada likely to be diagnosed with breast cancer in their lifetime, this important lecture walked our viewers through the signs of breast cancer, the evolution of breast cancer treatments, and breast reconstruction surgery options available to patients in Alberta. We are so pleased to have Dr. Peiris here with us today to answer your most pressing questions on breast health. And I will get us started. Thank you, Dr. Peiris. So with us this evening, we have women of all ages and all stages here. Can you tell us at what age women need to start performing self-checks on their breasts? At what age women should start seeking out their first mammograms? And does this change depending on their family history of disease?
Thank you very much, and thank you very much for having me here this evening. It's an amazing event, and I feel very humbled to be sitting up here talking to you guys, and just looking at the panelists that are up here, I hope I can live up to the reputations of those around me. So it's an interesting question, breast self-examination, because I have two lives. I have my previous life when I was in England, and my current life now I'm in Canada. And most of the time, those two lives seem to get along and have a lot in common. But sometimes there's a lot of differences in how we treat and advise patients with breast disease in England and how we treat and advise patients here. So in my previous life, I used to routinely tell women in my clinic to examine themselves once a month, usually the week after their period if they were still having periods. And if they were to find a lump, not to panic, because most breast lumps are benign and not malignant, but give it a month. And if it's still there, then to go seek some help from their family doctor and get a referral to a breast clinic. The public health doctors in Canada disagree with that. And so the official advice in Canada is that breast self-examination is not useful. And the reason for that is because, A, the belief is that it introduces anxiety. So if a patient finds something in their breast, that the likelihood is it's not going to be a malignancy. And so the first thing you think about when you find something in your breast is, oh, I've got breast cancer. My own personal opinion, for what it's worth, is I think that slightly undermines the intelligence of our patients. I feel as though if a patient finds something, then I think it's a good thing that they feel empowered to keep an eye on it and then go see a family doctor. So I'm sitting around a GP right now, so I need to be careful of what I say. But I do quietly encourage my patients, especially in my breast cancer patients, to get accustomed to what their breast feels like after breast cancer treatment. And in that population, their breast may feel completely different to how it felt before their breast cancer treatment. And I tell them that really what my role is to alleviate their anxiety. So if they find something in their breast, they should not be sitting at home worrying, getting more anxious, thinking perhaps I'm missing something. They should be coming to see me. I can organize a scan, I can examine them, and hopefully reassure them that nothing is going on in their breast. But maybe we'll find something that actually has to be treated a bit sooner than it would have been otherwise. So the official line is, in Canada, the public health doctors say we really should not be encouraging women to examine their breasts, but my own personal opinion is there really isn't any harm. And like I said, if you find something, it really isn't anything to get too concerned about, but perhaps keep an eye on it, give it a month, and if it's still there, then I think it's a good idea to get it looked at. With regards to breast screening, it's a controversial topic. So I think most people anywhere in the world, whether you work in medicine or you don't, would say that if you screen every 1 to 2 years with a mammogram between the ages of 50 and 74, then we do save lives. We catch cancers early. You only have to come and sit in my office once or twice a week to see patients who have a screen-detected cancer. It's small, it's very treatable, and you know, had they not been screened, they would have been presenting to my office a year or two later. It's larger, perhaps it's spread to the lymph nodes, and now the prognosis is not very good. So certainly my own anecdotal experience, and biased because I'm a breast cancer surgeon, is that screening does save lives. The controversy comes in the younger age group, between the ages of 40 and 50. And a lot of you may have heard in the news and the media recently that this has really caught a lot of media attention. And the issue is, it seems easy to say we should screen women from the age of 40. And most of the breast radiologists, those people that do screening and do mammograms and do ultrasound and biopsies, they themselves say we should be screening from 40. We miss a whole population of women who have breast cancer, and they are, quote unquote, missed because they don't get their screening mammograms. The downside of screening from 40 is that younger women have denser breasts. It's more glandular, it's full of milk ducts, it hasn't gone through the change of the menopause yet. And so mammography is not the most sensitive tool to find a breast cancer. So even if your mammogram is normal, between the ages of 40 and 50, it comes with a disclaimer that you may still have breast cancer. The flip side is, the denser breast also leads to a higher false positive rate. So you're told, actually, there's something in your breast on a screening mammogram. Now you get recalled, you get that letter saying, you need to come back, we need to do another mammogram, an ultrasound, and perhaps even a biopsy, which causes anxiety. So the debate that happens is it more important to try and find that small cohort of women in their 40s who have breast cancer at an early stage? Or is it more important to alleviate the anxiety that some patients might feel if they have an unnecessary biopsy between the ages of 40 and 50. The Alberta guidelines have recently changed, so screening can start from 45, and I do think it's a step in the right direction. You can have screening from 40 if you like. There is assumed to be a shared decision-making approach. So you go to your family doctor, you say, okay, I'm 40, 41, I'd like to have my first screening mammogram. You're then informed of the pros and cons, the risks and benefits of having a mammogram. And then patients will fall into two very different camps. Either they'll say, well, actually, I don't have any family history. I don't really want to open a can of worms right now. Maybe I'll wait till I'm 45 and then I'll start. Or they'll say, well, actually, I would like to be screened. I would like to know. I'd like to be proactive. And so they should be encouraged to screen in that scenario. So it is controversial. I think most people would agree screening from 50 to 74 is a good idea. I would agree that 45 is probably a better time to start. But between the ages of 40 and 45, we're seeing some controversy, and depending on where you live in the world, you'll probably have a different screening age to start at.
Thank you so much. In your previous presentation, you spoke with us about the modern era of breast cancer treatment, where you discussed what patients should be offered as far as treatment and recovery plans go. Can you share more about that with our guests here this evening? I
would love to. So one of my favorite statistics, and my my family and my kids especially get really bored with me because I like statistics. But one of my favorite statistics in my work life is that in the 1950s, in cancer surgery, we talk about 5-year survival, 10-year survival. It's just a means of trying to measure how many women with this cancer are still alive at 5 years, how many are still alive at 10 years, and it helps us to gauge how well treatments are working. So in the 1950s, the 5-year survival for breast cancer, any woman walking through the door of a surgical office with breast cancer was 50%. So 1 in 2 women unfortunately, would have passed away from their disease within 5 years. In 2024, the 5-year survival from breast cancer is 87%. So 9 out of 10 women are now living more than 5 years. And so there's multiple factors as to why the prognosis from breast cancer has improved so dramatically. And it's a multi-factorial event. We have screening is one. Despite all of the controversies we've had over screening, we've definitely seen screening improving the long-term prognosis of patients. We have better drugs. We have much more targeted chemotherapy. We have the advent of Herceptin, which is a much more targeted drug that we can give with chemotherapy. We have better hormone therapies for those women that have a hormone-driven breast cancer. I joke with my residents, we have better surgeons, but they never believe me when I say that. And we can target our treatments a lot better. I think surgically, we think a lot more about what we're leaving our patients with now. So in the 1950s, going back to that statistic, you probably would forgive surgeons for not really thinking much about long-term quality of life and what they're leaving these patients with in the aftermath of the effects of treatment. Because, let's face it, this was a really bad disease. Most of these patients were passing away. In 2024, we can't get away with that. As surgeons, we really have to think long and hard about the quality of life of our patients and the outcomes with which we leave them. So to give you an example, a lumpectomy, a standard treatment for breast cancer, taking a lump out of a breast in the 1970s, was not very pleasant. A patient came in, they had a large hole cut into their breast. It was sent off to the pathologist. They had a large scar. They perhaps had significant deformity, lots of asymmetry with the other side. Now they couldn't really wear the clothes they wanted to wear. They couldn't really wear a swimsuit. If they were trying to be intimate with their partner, they had to be careful about what they wore. So there were a lot of repercussions from breast cancer treatment. In 2024, we're really training our residents, and I was certainly trained during my training, to think long and hard about how we do something as basic as a lumpectomy. And this is not even thinking about a mastectomy and reconstruction. Something as simple as placing an incision in a hidden spot. So 90% of my incisions are either just around the areola, so that when a patient's in a bra, they can't see their incision. They're in what we call the inframammary fold, which is the fold underneath the breast, so that when you look down or look in a mirror, you can't see your incision. And so we do a lot of so-called plastic surgical procedures to try and preserve breast shape, preserve breast asymmetry, and therefore, as a knock-on effect, hopefully preserve long-term quality of life. So I always say to my patients, the number one objective here is to take your cancer out and take it out safely. But if I can marry that with maintaining your breast volume, maintaining your breast symmetry, and therefore hopefully maintaining some semblance of quality of life, then I think that's a job well done. So I think there's lots of things that we can do now to offer our patients, surgically especially, that our predecessors 30, 40, 50 years ago just couldn't do.
Thank you. Getting a little further into the surgery conversation, you did talk a little bit about Wirefree Technologies at the time as well, so MagSeed, EndoMag, and MagTrace. Can you talk a little bit more about what those are, what they mean for surgical treatment of breast cancer in the future, and whether that technology is available yet for patients in Alberta?
Sure. So patients that come to see me with a breast cancer, they fall into two main categories. Either they can feel a lump, I can feel a lump, and so a lumpectomy surgery is pretty straightforward. I know exactly where their cancer is. I can feel the margin of safety that I want to take around that cancer, and so that's pretty straightforward. But now we're living in a world where a lot of women have a screening detected cancer, so it's so small they can't feel it, I can't feel it, but we know it's there because the mammogram has shown us it's there. We still need a way of knowing where it is for the day of surgery. We don't like to guess, I tell my patients. We need to be very targeted with our surgery. And it might pain you to know that a lot of women for the past few decades have had to go into a radiologist's office on the morning of their lumpectomy, have an ultrasound, and have a wire poked into their breast, which is then left there for the day. They then come to the hospital, and when they're asleep, I can take the dressing off the wire. When they're asleep, I follow the wire down, and I know where it is. Now, asking a patient on probably one of the hardest days of their lives to have a wire stuck into her breast is a big ask. So for a long time, we've been looking at alternative technologies to try and localize these lesions without having to subject patients to that kind of trauma. And one of the main technologies that we're looking at, which has really grown in speed globally, is the mag seed. So the mag seed is a tiny little magnetic chip. It measures only 1 millimeter or 2. The radiologist puts that little magnetic chip into the middle of the tumor a day, a week, even a month in advance. And then in the OR, we can use a special navigator, it looks like a Geiger counter, and we can find the chip inside the breast when the patient's sleeping, and that way they don't have to have a wire in their breast. We still have the ability to find their tumor, and they have a much smoother transition through their breast cancer surgery. So the downside with seed technology is it's expensive. And when you're trying to convince the publicly funded health system that we live in that we have this technology, it's much better for the patients, but it's going to cost you more. Usually we get doors slammed in our faces. When the hospital finance or the AHS finance people try to listen to new technology, they want to hear, is this going to save us money? They don't want to hear, this is going to improve patient outcomes and improve patient quality of life. So it's taken a long time. Calgary have just got foundation funding for a magnetic seed program within the last month. It just hit the news. Edmonton does not have funding yet. So we now have a 2-tier system where if you live in the south of the province, you will have a seed placed into your breast in advance. If you live in the north of the province, you will have a wire placed into your breast. And so we had a meeting on Friday, and we said this is unacceptable for our patients in Edmonton. So where technology is going, we're looking at wire-free seed technology. We just need to try and figure out a way to try and fund it here. Thank you.
Building upon that, are there other advancements in care plans and technology that we are still working toward improving here in Edmonton and in Alberta? And how can support from donors like those that you see here in the audience tonight help advance these areas?
So I'm very lucky because breast surgical oncology, breast cancer surgery, is a very innovative field. We have lots of technology. I go to the conference in the US once a year, and every time I come back, I've got a shopping list of things that I think I need to buy. So there's something called a facetron machine. Some of you may have heard of this. We purchased one at the Misericordia Hospital a few years back. A facetron machine allows the surgeon to put a lumpectomy into an X-ray, which is a portable machine. You can even bring it into the OR with you. Think about putting a bun into an oven, and then within 20 seconds, it gives you an instant X-ray of that lump. And that's important because when we do a lumpectomy, we want to not only take the cancer out, we want to take it out with a clean margin. And margins are sacred in breast cancer. If you have a positive margin, you have a higher risk of a recurrence of that breast cancer. And so we'd come back another day, subject the patient to a second surgery, take a bit more tissue to render their margin clear. If we have an intraoperative X-ray machine, lots of studies have now shown that by utilizing that, we can actually reduce the number of patients that have to then come back for a second surgery, which frees up the patient because they don't have to come back to hospital and see me and have an operation. It frees up the hospital OR list because now we can put a new cancer into that slot that otherwise would have been taken up with a margin. And it frees up public health dollars because it's expensive for me to operate on somebody. So a facetron machine, since we got it at the Misericordia, has more than paid for itself. We're currently refurbishing one of our other operating rooms at the Cross Cancer Institute. And they're asking me, well, how can we make the flow of patients easier? And we have no facetron machines. So facetron machines really have revolutionized breast cancer treatment and lumpectomy surgeries. There's lots of other things I could go on with, but I won't bore you with them.
We do participate in the fall as well with an event called Broad Day, which talks about breast reconstruction awareness. So stay tuned. You're now all connected to us. There will be more content to come on this breast reconstruction and treatment area. But are there any other questions for Dr. Peiris this evening? We've got one here. Tamar's coming, and one just in behind you as well.
Check, check.
Perfect. Just over here. Or you can yell, Vicky, for now.
Oh, no, that's good for me. Do you mind just repeating that just for the video? Just so people online can hear you.
I'm just wondering, with you talked about the technology being available in Calgary, and obviously we're all under AHS, so I'm curious as to how that was funded and how do we get that in Edmonton?
So this is a great question. And I'd love to give you a straightforward answer to that. We ran a provincial pilot study 2 years ago. One of my colleagues led the study where we used magnetic seeds in our hospitals in Edmonton. We got through 50 cases per hospital. We proved it worked. We proved it was feasible. We proved it was a good way forward. And that pilot study ran for a year, and then it stopped. And then the people that ran the pilot study, the scientists that ran the pilot study, said, okay, now it's feasible, so it's over to you. You can now use this piece of equipment. You just need to find the funding. How did Calgary get to use it? They got Calgary Foundation money, is what I hear. The surgeons in Edmonton, me included, were slightly frustrated with that because this was always supposed to be a provincial pilot, a provincial initiative, and we'd all go into this together. And it really feels a little bit like Calgary have found their own money, and so they're now saying goodbye to the rest of Alberta, and they'll do it themselves. They've found the funding. Foundation money, I've grown to learn, is not operational cost. Operational cost means it's built into the budget of the healthcare system. So every time I put a breast implant in for a breast reconstruction, or every time a radiologist does an ultrasound, this is all funded through the healthcare system. Once you introduce new technology, you need to find funding to run that technology day to day. It's not like buying a Faxitron and using a Faxitron. It's a one-off cost. With a MagSeed, it's a repeated cost, day in, day out, week in, week out, month in, month out. So when the Calgary Foundation money runs out, let's say it's $3 million for the sake of argument, you wonder what's going to happen next. And I suspect they're going to say, well, this is now standard of care in Calgary. We've been doing this for the last 3 years, and so now we have to do this moving forward. It's much easier to continue to do something that's already standard of care than what we're trying to do is introduce something. So we're all ears open. We just had a meeting on Friday. We're exploring all kinds of avenues to try and get funding, one of which obviously is going to government, but we all know how long that takes. So watch this space.
I think just in the back row as well. Yeah, she's got her hand up there.
Just had a quick question about dense breast screening. And I know like the A-bus first came to Calgary and then eventually came here as well. But what particular test or what is the data in terms of what is the best test to do for dense breasts? Just because most people can't do self-tests or self-exams. So MRI, A-bus, ultrasound, is there any new emerging data?
It's a great question. So for those that don't know, I say this to the residents and the medical students in my clinic, every mammogram you see today when you are with me is going to be a different mammogram because every woman's breast is made differently. Breast is made of 2 types of breast tissue, glandular breast tissue, which is the milk duct system, and fatty breast tissue, which is the tissue that surrounds it. And every mammogram I see has a different component of glandular tissue to fatty tissue. Some women have very dense glandular breasts, some women have very fatty breasts. Fatty breasts, because they are essentially black on your screen, so even a small little tumor, it's very easy to interpret. It's a very sensitive tool. It's very easy to pick up cancers. The problem comes with dense breasts. We didn't really understand dense breasts until 10, 15 years ago. There's actually a group here in Canada that have advocated for women with dense breasts to be told, you have dense breasts, you need to have extra screening. And they've done a huge amount of work in patient education and trying to raise awareness, because now, thanks to that group, every radiologist, when they do a screening mammogram, they have to grade the density of the breast from A to D, I think it is, where if they've got dense breasts, they're then told, okay, you have dense breasts, A, this reduces the sensitivity of a mammogram, and B, it's actually a risk factor for future breast cancer. So how can we screen these women more effectively? So every radiologist will still say mammography is the best screening tool. So for sure, mammography is the first thing to do. Supplemental ultrasound, you talked about ABUS, so ABUS stands for Automated Breast Ultrasound. Think about the ultrasound that most of you will have had, which is a small ultrasound probe that you run across a body part. An ABUS looks like an iPad, and so it's a panoramic ultrasound that you run down the breast, and you get a panoramic view of the entire breast. And it's almost like a 3D ultrasound of your breast, and it has been shown to improve detection of cancers in dense breasts. So most modern guidelines will say that if you have dense breasts, for sure you should have your regular mammograms, but you should have supplemental ultrasound, either with ABUS or with a handheld ultrasound, preferably ABUS. MRI is a bit more controversial. So there are roles for MRI in breast health. There are very specific roles for MRI in breast health, but to start screening with MRI has its downfalls. MRI is extremely sensitive. In fact, it's almost too sensitive in the breast. Remember I said that mammography can sometimes miss things and it's not a very sensitive tool sometimes. Well, MRI is the opposite. It overcalls things. So now we do an MRI on a patient who actually doesn't have cancer. But now we pick up a little blemish, a little spot. Now she has to come back, have an ultrasound. Perhaps that culminates in a surgery, all because she had an MRI in the first place. So we're quite cautious with screening MRI. There are women, the high-risk population, so those who have the BRCA1 mutation, the BRCA2 mutation, those have a very strong family history. Those women are encouraged to screen with an annual MRI and an annual mammogram, but offset by 6 months. So they get something every 6 months. Over and above that, screening with MRI is a little bit controversial.
Okay, thank you so much, Dr. Peiris. We are going to move on to our next panelist, Dr. Briana Botsford. Dr. Botsford is a naturopathic doctor, an Ironman triathlete, and I can see that mark there on your leg that proves it, and proud owner of Flow Functional Healthcare in Edmonton, Alberta. Her personal journey in sport and wellness inspired her special interest in the intersection of sports medicine and women's health. Through her practice, she focused on empowering athletes and active individuals through personalized nutrition, lifestyle changes, and targeted supplementation. Brianna is also a part of our Lois Hospital Women's Society and a volunteer on the communications committee as well. And if we were virtual tonight, she would be sitting in this host as moderator. So many of you may have seen her on our virtual sessions where Brianna has played that role again and again and again for us. So thank you, Dr. Botsford, so much for being here this evening.
Thanks for having me.
So Dr. Botsford is going to talk to us a little bit about bone health this evening. And just like the question about breast health, there are a wide variety of ages here in the audience. So we were hoping you could expand for us on what women of all ages need to know about bone health and at what age we should start paying more attention to the signs of potential challenges.
Yeah, and thank you for the question. And it's funny to be back here at the Glenora because when I first became involved with the Women's Society, I came here and we did a session that had a different name, Lady Talks maybe at the time, and it was about bone health. So I'm back and we're talking about the same thing. But I think you can always hear something new when you hear the same topic again. So with respect to bone health and why it's a topic I'm so passionate about is because I think we all know about osteoporosis, but what I don't think a lot of people realize is that we reach our peak bone mass in our 20s as women. And so we do start to lose bone mass every decade. And that really starts to accelerate in the fourth decade. In our 40s, we can lose quite a bit of bone mass, and it accelerates towards our seventh decade of life. And so one of the most important things that we can do is remain physically active with weight-bearing physical activity. And so while things like swimming and cycling might be quite good for people with sore joints and things like that, actually loading our tissue with our own body mass or something that is heavier than our body mass, so things like weightlifting, running, jumping rope is actually incredibly well researched for bone mineral density specifically. Now I know that brings up a whole bunch of when you talk to a bunch of women, they're like, but I pee. And there is pelvic floor physiotherapy for that, and you should watch our last Between Us was with the pelvic pain clinic, so you can learn a whole bunch from them too. But when it comes to what you should watch out for bone loss, fractures over the age of 40, especially non-traumatic fractures. So somebody that has a stress fracture or like a repetitive use injury in a bone, those are patients that may be at a higher risk for osteoporosis. Patients that are on certain medications like corticosteroids, so things like prednisone, can accelerate bone loss. And so those are people that are at a higher risk at baseline. We don't usually screen screen patients for osteoporosis or osteopenia, which is sort of the prelude to osteoporosis. It's mostly bone loss, and we changed the diagnosis or the name based on what's called the T-score, which is a score that you'll get on a DEXA scan, which is the bone mineral density test. And right now, the screening guidelines are that we screen over 65, which sounds like it's pretty late in life, but right now where the research is showing us is somewhat similar to breast cancer research, where we're seeing that earlier screening doesn't necessarily change outcomes. And so that's where this guideline has come in. However, patients that do have non-traumatic fractures over the age of 40 and then a whole host of other risk factors are recommended to have earlier bone mineral density screening. Loss in height, there is a number, I think it's more than 2 centimeters. And then also family history plays into that as well. People who are very underweight have a higher risk for osteoporosis. And this is interesting because we've classically thought that being overweight or having extra mass is protective for our bone mineral density. If you think about what I just said about weight-bearing physical activity and how having extra load on your body can protect your bones, you think, okay, having extra body mass, whether that's overweight or obesity, might be protective for my bones. And that might be true to an extent, but there's also an incredible inflammatory cascade that happens with changes in body mass. And we also see that patients who have extra body mass, it may not always be muscle. And so muscle is your superpower to protect your bones, your metabolism, and of course your quality of life and your function, being able to stay active as you advance in your lifespan.
You mentioned osteoporosis, and of course we all have heard about that and think about that as we age. What should women know about it, and can you share some guidance on how to maybe identify some of the signs of reduction in bone density?
Yeah, so those non-traumatic fractures, loss in height, being very slight, but also when, not so much the signs or what you should look for, but what you want to be aware of is actually more related to your nutrition and, of course, like I said, your activity level. So when we look at your nutrition intake, we want to make sure that you're getting adequate protein. And everybody thinks, you're talking about bone health. Why are you talking about protein? Shouldn't you be talking about calcium and vitamin D? Yes, that's later. But the first thing we want to talk about is total protein intake, because protein helps us to maintain our lean muscle. What did we say about lean muscle? It helps us to maintain our bone mineral density. So when we look at protein intake, the guidelines go up as we advance in our lifespan, which is also something that people don't think about a lot. They think, well, I'm getting older, I'm maybe less active, I need to eat less, or my appetite is lower, but actually our protein requirements go up, and that's for 2 reasons. One, we don't absorb protein as well from our diet as we advance in our lifespan. The other piece is that when our estrogen levels decline, so in perimenopause and menopause, it's more difficult to maintain our lean mass. And I think, so that's muscle and bone. And I think it's important to understand that menopause is a risk factor for osteoporosis. And I don't think that's something many people can identify or pick out. So early menopause, or anything before the age of 40, would be considered a risk factor for osteoporosis as well. But then when we go back to that protein intake conversation, when estrogen declines, it's more difficult to maintain that lean mass, so muscle and bone. And so our protein requirements go up. And so typically the recommended protein intake for an adult is 0.8 grams of protein per kilogram of body weight per day. And you're all like, those are numbers. I don't know what they mean. When we advance in our lifespan, we're looking at 1.6 grams of protein per kilogram of body weight per day. And so that's double. What does that look like for a 68 kilogram or 150 pound person? That's looking at close to 80, 100 grams of protein a day. And so you're like, okay, cool, still numbers. What does that mean? When we look at what that actually means, a chicken breast is about 25 grams of protein. 3/4 cup of Greek yogurt, 18 grams of protein. Okay, so people are constantly, I just had this conversation in my office every single day. We're talking about how do you actually meet those requirements that are necessary. And so you can see why diet and lifestyle can play a significant role in this disease progression. Of course, there's many other sources of protein. Just Greek yogurt and chicken were like the easiest ones. But eggs, eggs are a great source of protein. You can get 12 grams of protein from 2 eggs. You can look at your lentils, chickpeas, legumes. That would be more in line with a Mediterranean style diet, which actually has good research for osteoporosis and, of course, many other health conditions, heart health, and so on. And then, so those are your plant sources of protein, and then, meat, fish, et cetera.
And those cottage cheese wraps that everyone's posting
apparently
on
cottage cheese
TikTok
is
and
trending on
various other
TikTok.
places. Yeah, cottage cheese, everything, which I'm a big fan. I eat it
Calcium,
every day. Absolutely. So there's another osteo that often comes up when you talk about bone health, osteoarthritis. What causes should we know about? What do we need to know about prevention and treatment? And does running cause it? Because that's another question that we hear often as well.
So osteoarthritis is wear and tear in your joints. We all have it. If we took x-rays of all of our bodies, we would see some level of joint degeneration in some part of our body. And so it's related to the wear and tear. I always joke, like in osteoarthritis in your neck, we all probably have it based on carrying a bowling ball on top of a bunch of little vertebrae for as long as we've been alive. Now, the question is, if we have osteoarthritis, is it causing pain? So sometimes imaging, so x-rays, don't always line up with a patient's pain. Now, knee osteoarthritis is probably the easiest example to use. When somebody has bone-on-bone osteoarthritis, it means the joint has degenerated to the point where the bones are now rubbing against each other, and there's no room for lack of friction or lubrication in the joint to keep it healthy. And so those patients are usually going to be candidates for joint replacement depending on other factors. But when we look at osteoarthritis, oftentimes people are concerned that their activity level is going to worsen their condition. And we have so much evidence that activity does not worsen the progression of osteoarthritis. So does running cause osteoarthritis? Not necessarily. It also doesn't necessarily make it worse. So seeing a really great physiotherapist can be helpful to address any muscle imbalances that could be present. There's many different therapies available for osteoarthritis, different injection therapies, of course, medications, and then staying active. We talked about how, the pool and the bike might not be the best for our bone mineral density, but they certainly can be great for lower body osteoarthritis or pain in those lower body joints.
Wonderful. Any additional questions on anything bone health? I think Rhiannon in the front here.
Check.
Thank you. I have a question about bones in earlier life. So when children are going through growing pains, is that like a pain from like quick growth of bones, and how do we help them deal with that? I don't know if that is a bone question, but I feel like it kind of is.
Yeah, it's a good
Thank
question. There's rapid skeletal development in our little ones. Certainly in my practice, we'll look at how's their nutrition, like are they getting adequate protein, calcium, vitamin D, all of those things. Stephanie, do you have any thoughts on that?
Thank you. I think that's great. Nutrition plays such an important role in our bone health. And growing pains, I don't know specifically what causes it, but we know that it does happen for many of the little ones. I always, as a family doctor, it's my job to always make sure I never miss anything that's really bad. So if a little kid has growing pains, resolves after a few weeks, I don't care. But anything where there's persistent pain in the bones and it's severe, it's waking them up multiple times at night, I always recommend checking in with your care provider just to rule out anything that could be potentially dangerous.
Any other questions? And right here in the front, Tamar Charlene has a question.
Thank you, Dr. Botsford. My question is about hormone replacement therapy and whether there's a connection to hormone replacement therapy and the ability to stave off the effects of osteoarthritis, perhaps, or is that proven?
So, yes, and osteoporosis, so bone loss specifically, hormone therapy has been shown to slow the rate of decline of bone loss. However, that's not an indication for hormone therapy the way that we understand it right now. What that means is that if somebody is coming in, they're not experiencing symptoms of menopause, so hot flashes, night sweats, and those sorts of course, there's many other symptoms, but it's not an indication to start them on hormone therapy as a preventive tool for osteoporosis at this time. I think that we're going to see more and more evidence in this area, especially with the huge amount of women going through perimenopause and reaching menopause. And I think we're going to get more data and that might change. But right now, we are not recommended to recommend hormone therapy for patients simply for cardiovascular disease prevention, because that's another thing that it can do, or assist with rather, and then bone mineral density. It's the gold standard for hot flashes and night sweats. Of course, there's many considerations that have to come into that prescription, but it can be helpful, but it's not the gold standard treatment for osteoporosis. Does that answer your question?
Thank you so much. Okay, I think our final panelist for the evening. We'll pass the mic down one more time. Dr. Thomas Nakatsui is the medical director of the Nakatsui Dermasurgery Center, a certified non-hospital surgical facility in Edmonton. He holds a fellowship in dermatology in Canada and is also board certified in the United States. Dr. Nakatsui is skilled in all areas of dermatology, including laser surgery, fillers, Botox, and hair transplantation. He completed his medical training and residency in dermatology at the University of Alberta in Edmonton and received additional training at several centers of excellence, including the Harvard Medical School and the Massachusetts General Hospital in Boston, the Johns Hopkins Medical Center in Baltimore, and the Mayo Clinic in Rochester. No big deal. In addition, he was trained personally by dermatologist Dr. Don Groot since July 2000 in the use of lasers, Botox fillers, and other treatment modalities. Dr. Nakatsui has won numerous awards and scholarships. Among them, he was accepted into the prestigious Alpha Omega Alpha Honor Medical Society. He prides himself in the care of medical and cosmetic dermatology needs of his patients. In September of 2022, Dr. Nakatsui provided an overview of skin cancers, precancerous skin conditions, common skin conditions and aging, as well as treatment options and the warning signs we should all look out for when assessing potentially cancerous lesions on spots on our skin. Dr. Nakatsui has joined us this evening to share his knowledge and answer any questions our audience has. And beyond that, the Nakatsui family is also engaged with us in many ways. They have been connected to our foundation for many years, being part now of our Royal Willow Society as legacy supporters of our hospital. And once again, they will be joining us as Harvest Celebration hosts, as you heard about Harvest Celebration earlier this evening. His wife Melanie and him are two of our four couples who will be guiding us through our Harvest Celebration this year. And we could not be more grateful for your support, Dr. Nakatsui. So welcome and thank you for coming.
Thank you.
So the sun is shining, finally. The rain is over. What is the truth about SPF levels? I know I'm confused. I'm standing there in Shoppers Drug Mart and thinking like 15, 30, 60, 80. I don't know what to choose. How should we be making the right choice for our skin and for our children's skin, and is there a difference?
Well, that's a great question. First of all, I want to say thank you for the introduction and thank you to the Lois Hole Hospital Women's Society for inviting me and all of us to speak tonight. I have to apologize for stepping away, but I hadn't had any supper, and I think I was getting hypoglycemic. So I'm like, before I pass out, I better get something to eat. And I thought maybe I need some of that POM MD, actually, to keep me going. But I figured you didn't have any, so I thought I better get some. So in terms of your question about the SPF, that's a great question. It's actually a question I'm almost never asked, actually, but it's a good question. So SPF stands for sun protection factor, and it refers to the factor by which the sunscreen will enhance the ability of the skin to prevent a burn. And so if you have an SPF of 30, then basically it's 30 times the amount of natural skin protection. So for example, if your skin would burn in 10 minutes, theoretically you could spend 300 minutes out there. Although it's not an excuse to not reapply the sunscreen, because that sunscreen wears off. So every 2 hours you should be reapplying that sunscreen if you're outside. And so, as a man, I'm actually very bad at putting sunscreen on. I hate to admit that. But there's many times when my wife is yelling at me from the front door. She's like, "Do you have sunscreen on?" Sometimes I don't, but I should. But women also sometimes don't reapply sunscreen either. Because you have makeup on, it's kind of hard to reapply sunscreen. But there are now some powder sunscreens that we have that you can just put on over top of your makeup. And so there are ways to kind of reapply this without disturbing the makeup that you have. But your question was going back to the SPF 15, 30, 60. So as I was saying, it refers to the factor by which you can stay out in the sun without burning. And so is it better to have 30 than 15? I would say for sure. And our recommendation of most of the societies is that you use at least an SPF 30 or higher when you're outside. The other question, though, is it better to have a 60 or 100 rather than a 30? And there have been some studies to show that if you apply SPF 100 versus SPF 50, for example, that there's way less people who get sunburns. And part of the reason could be that some of us don't apply enough sunscreen. So if you put on 100, a small amount, you'll maybe get the same effect as you would if you put a lot of the 50 on. So you actually will have some benefit from that. There's actually a TikTok thing right now where they're saying that sunscreen is dangerous for you, which is not, as far as I'm concerned, is really toxic, I guess, in the sense that, it's actually dangerous, because we know that even if you get a sunburn before the age of 20, that doubles your risk of melanoma, which is a really bad skin cancer to get. So it's really important for all of us to use sunscreen and to apply it frequently if you're outside. And I think I forgot your other question. Oh, the question about for children, right?
Just children, yeah.
Children, yeah. So with children, the recommendation is that after the age of 6 months, you can safely apply sunscreen. So I would, recommend that if you're going to, if you have young children, you should be using sunscreen if they're outside. You don't have to apply lots of it necessarily, but definitely apply some. If you're concerned about anything that's bad about sunscreens, of which there's no proof there is, but if you are concerned, then I would use the titanium or zinc ones. So these are the inorganic or mineral ones, and those are considered really the safest sunscreens to use.
So if we continue on that, because we know everyone really wants to have a tan for the most part. Is there any thoughts or advice? Is self-tanners, are they safe? Are they good for your skin? Is there any safe way to kind of get that glow that everyone's seeking without damaging our skin?
Well, self-tanners are safe. So basically it just stains the skin. So you're putting a stain over your skin. And it does give a little bit of sun protection. It's definitely way better than going to a tanning booth. So if you go to a tanning booth, you're increasing your risk of skin cancer. So basically, we're trying to protect ourselves against UV light. So there's UVA and UVB. So UVB is the burning sort of rays, and UVA is the kind of aging rays. What UVA does, if you get a lot of UVA, which you would get from a tanning booth, it would stimulate oxidation of melanin. So it makes it look darker. So we call immediate pigment darkening. But it doesn't actually increase the amount of melanin that you have in your skin. So you're not actually protecting yourself very well from that sun, or the damaging parts of the sun. If you have more melanin, you are protecting yourself. So it's one of those things where tanning booths, they make your skin look darker, but you're not actually getting very much extra protection from the sun with UVA light. So the spray tan, like I said, it is helpful. It does stain your skin and gives you a little benefit. But the actual sun tanning booths, I would highly recommend you stay away from.
So for anyone who tends to go on vacation and not wear sunscreen, it's probably not a great idea.
No.
That's good to know. So as someone with many, many freckles, I can speak for myself. How do we know when something's dangerous? Or how do we know, like, how do we keep track? I mean, should we be taking pictures of them? What do we watch out for? I think we've all heard the ABC kind of, but maybe you can walk through for people what we should watch for.
Sure. Well, the first question about taking photographs of it, I think is a useful one, and sometimes I recommend to patients too, if they're concerned about something, just take a photograph. That way, you have something you can always compare to. Don't look at it every day, because if you look at it every day, you're gonna drive yourself crazy, and you'll think that something's changed when nothing's changed. Maybe it's the same for a breast lump too, I don't know. But so it's one of those things where if you do take the photo, look at it every month or every few months, and then you can actually see if there's any distinct change. It is difficult because there are some benign things like seborrheic keratoses which look dangerous, and they often change, and we don't have to do anything about it. But it would be hard for you maybe to tell what that is for you at home. So you want to see your family doctor, you want to see your dermatologist, and they can give you a better idea whether that's safe or not. But if you don't know whether it's safe or not, then we kind of use the ABCDs that you were talking about. So A is for asymmetry, and so that's if you drew a line kind of through the middle of that lesion, could you fold it on itself and have it look the same? So if you could fold it one way, it looks the same, you fold the other way, and you're like, no, that doesn't look the same at all, then there is a problem with the symmetry. B is for border. So we like to see a nice, smooth border, but if you get like a notch in it or something like an arm sticking out of it, well, then potentially that's more dangerous. Color, the more colors you have, the more dangerous it is. So if you just have this one even brown, that's no problem. But if you have light brown, dark brown, you've got black, you've got red, blue, that's really a little concerning. You should see someone like right away. D is for diameter. So we often use the pencil eraser sort of number. So if it's smaller than a pencil eraser, then most likely it's not a problem. But there are spots that are larger than that aren't dangerous. There are spots that are small that are dangerous. And so we often rely on E, which is evolution. So if it's changing quite a bit, then we're more concerned. Like if you've always had a spot that was, 10 centimeters wide on your thigh, but it's been there since you were, 2 years old, and it hasn't changed very much, then we're not too concerned. But if it went from 1 centimeter to 2 centimeters over the course of a month, then we'd be really concerned. So those are kind of the main things. The last thing would be the ugly duckling syndrome. So if you look at someone and you see all these spots on them, and there's one that's just different than all the others, like it's super dark, and it's quite unlike the others, and sometimes that's the one we need to take a look at. And it may be nothing. It may be this benign seborrheic keratosis, but you won't know until you get it checked out. And so it is valuable to do that.
Thank you. Age spots is something else that came up from the audience when we were asking for questions. So many of us have them on our face, on our hands. I think they tend to find themselves on the places that see the most sun. Can you talk to us a little bit about them? Is there treatment that we could lighten them with? Can we, is there help at your office? Because I know it's something that many of us concern ourselves with.
Well, like you said, it's definitely in areas where you see more sun. So, because in the past, I haven't been as good at sunscreen. I'm better now. But, I have that spot, that farmer's can thing where you can see all these little spots on my arms where I had the sun. But anywhere else that was covered, I almost have nothing. So it definitely is related to the sun. Now, in terms of what to do for them, if they're benign, you definitely can treat them. So we can use creams sometimes to lighten them. Although creams usually won't get rid of them completely, they will lighten them. More often, we will use a laser. So there's lasers that can get rid of it. There's something called intense pulse light that also can help. So there are ways that we can lighten these if we want to. But first, you have to make sure it's not dangerous. So again, if you don't know if it's dangerous or not, you should be careful about just lasering them.
Sure.
I think another common complaint is especially a lot of women have roles that demand them to be on their feet for many, many hours a day, whether that be in the workplace or the home. And often you see that that's causing varicose veins. Once we have them, is there ways to treat those? And are there things we can do to prevent them as well?
Yeah, there are ways to treat them. So as you said, being on your feet all the time kind of predisposes you to it. Pregnancy predisposes you to it. Being overweight, some is just genetic. Some people just have weak valves in their veins. And if those valves burst, you're more likely to get these dilated veins. In terms of treatment, if they're really small, we'll usually inject them with sclerotherapy, and that's enough to kind of sclerose them shut. But if they're really large, you need to use something called foam sclerotherapy, or sometimes use like an endovenous treatment, so endovenous ablation with either radiofrequency or laser to actually close off those valves. And if you can close off those valves, then you can improve the appearance of those quite a bit.
Another question that I'm sure came to us many, many times was about the therapeutic treatments of Botox and how that can be used. Because I think we all know the social, everyone thinks about, getting rid of wrinkles, things like that. But can you talk to us a little bit about what other therapies and what other ways Botox is being used?
Botox is amazing, right? So one of the things that's really good for actually is migraines. It's one of those things where we can inject various areas of the scalp. We can inject the temporalis muscles, occipitalis muscles, cervical paraspinal muscles, trapezius, and we're able to really help people with migraines frequently. It doesn't work for everybody, but for those that it does help, it's really life-changing. Like, I don't know how many of you have had migraines, but I've had a few in my life, and I would never wish that on anybody to ever have a migraine because they're horrible. So if we can give people relief, or even get rid of say we got rid of 10% or 20% of their migraines, it's actually worth it, I think, because even one less migraine per month would be worth it in my mind. The other thing is hyperhidrosis or excessive sweating. So we can use Botox to stop the signal to the sweat glands, so the body just stops sweating from those areas. And so we can do that in the axillae, we can do it in the palms, the soles, we can do it sometimes in the scalp if necessary. So it's really a nice therapeutic area that really helps.
Wonderful. Any questions for Dr. Nakatsui on anything skin related? I think we have one here, Tamar.
Thank you. I will also admit I'm not the best at putting sunscreen on. I do tend to do it if I know that I'm outside, but specifically for like your lips, I will put it on, I'll kind of like rub it on my lips, I'll like occasionally put a lip balm on, but my lips are always sore. So I realize you probably have to be putting it on more frequently. So like how frequently, if you have an idea?
Well, again, probably every 2 hours is probably what we recommend. And there are some sun protective like sticks almost that you can just kind of put over your lips, and so that might make it easier for you to apply. Thanks, good question.
Stick with you, you're closer.
Make our way.
This is not, with all the expertise on the panel, perhaps you can address this. If you're not comfortable, that's okay. But hearing you talk about children and sunscreen, I don't have any young children anymore. But one thing I've seen, teacher, is more and more children wearing sunglasses outside. And I don't know if this is something that you can speak to, if it's more protective of their eyesight. Maybe our doctor can speak, so one of them can speak to that. I'm just curious about that because it seems more of a trend. And the last thing I'd like to say is thank you for staying in Alberta. Thank you for staying here and practicing your specialty here or coming here from another country. You are valued, you are important, and don't ever forget it. Thank you. And thank you to all that arranged this tonight.
Thanks for that comment. I don't know much about the eyes. Someone reminded me a few years ago, they said, you know that your knowledge about eyes is like over 20 years old, right, for medical school. So I'm like, yeah, I don't know if I remember. But I think that in general, sun protection for the eyes is probably important. I would say it is. Just like the skin, all that sun is causing some damage. But maybe someone else can speak to that.
Yeah, Sue, great question, and you're absolutely right. UV rays can damage the eyes. So sunglasses actually are recommended for little ones, and they're actually recommended for all of us, because over time the UV rays will damage our eyes, and I also think the kids look real cute and cool in them too.
A skin question, skin tags, is that just part of having skin, or is that an indicator of something else, maybe more nefarious going on?
Typically, having skin tags is very normal. I've had a few. I like to get rid of them because I hate them, but they're not dangerous in any way. They usually appear in areas of rubbing, so in the armpits, the neck, the eyelids, the axilla, the groin, anything like that. Very, very common, but not dangerous.
Any other skin questions or just any questions in general we could certainly take? A couple at the very back. Getting Tamar's steps in for the evening.
Hi, my name is Renee. I just have a question. So from here, your skin looks perfectly great, like actually great. So if it's sunscreen that's helping, I'm gonna start wearing sunscreen.
Thank you. Thanks, my wife.
Because you're glowing from this direction. But I do travel quite a bit, so I've got friends from different walks of life, and I wonder, and if you can share your thoughts around that, about the skin tone and use skin color, so lighter versus darker. I find that like if I go on vacation with my friends, they can lie in the sun, back out, butt out in the sun, and we're both wearing sunscreen. However, me having darker skin, I find that the sun, I actually burn to the point where it's uncomfortable, whether I'm wearing sunscreen or not. So I wonder, I understand you explained, 15, 30, 60, 100, but is there anything around skin tone color and whether it's recommended to use higher versus lower, if you can share around that?
Well, typically, someone with a darker skin type should be protected. I mean, typically that's more protected. So if you have a darker skin type, I would have expected that you would be less likely to burn than someone that has a lighter skin type. So it's interesting to me that you tell me that you actually burn very easily.
Yeah.
There are, definitely people who are more photosensitive for various reasons, and that can be medication related sometimes. Sometimes it can be genetic, but so that might offset the protection that you're getting from the increased melanin in your skin. So there might be some other reasons why that's happening, but typically you should be, everything else being equal, should be more protected. So in your case, if you are more photosensitive though, you probably should be using a stronger sunscreen, so a higher factor. So if you're using SPF 30, maybe you should be using 100 or something to give you that protection. And you should always make sure that you're reapplying. And you want to apply about 15 to 20 minutes before you're going to go into the sun. So don't apply it just immediately. But, I said it's kind of an unusual case.
I do know it's unusual. But thank you. That helps.
Thanks.
I think that's all we see. So I will share my gratitude to all of you on behalf of everyone here, to our panelists, and thank you to all of you for coming. I'll pass it back over to Katrina just to close us out for the evening.
Okay, everybody stay there. One more round of applause.